Yeah, so that's my charge, to speak about the playbook. But I want to just react to two things you said, because I think they're really important. One was about needs. And as somebody in a coffee shop line said to me once, you know, it's great when you talk about population health, but don't forget that there are individuals in that population who have specific needs and seek health, well-being, and dignity. So couldn't agree with you more about that. And I'll be talking a little bit about scaling because you mentioned that in context of the playbook. I'd just like to remind us that to scale something is not an accident, it's a science. And so we'll talk about that a little bit. But first, this is a terrific report. I think that every leader who wants to improve outcomes and lower cost of patients with complex needs should read it. And in fact, since this is the word of the day, I pressure tested this on a flight, a JetBlue flight, when I read it cover to cover and somehow did not turn on the free TV to watch my favorite shows, Flip or Flop and the Property Brothers. So you know this is a good read. For those of you who said it's an easy read, it's a good read. It's really an excellent companion to the playbook, and so it's fair to say, how does the playbook complement the NAM report? What goals did the 5 foundations have in mind when they commissioned IHI to begin to work on this online resource? And I'm going to actually recite verbatim the aim for the playbook that we were given, because each word is really very weighty. The playbook provides users with the best available knowledge about promising approaches. You notice it's not proven in a randomized controlled trial, because, as we'll see, there aren't many of those, but promising approaches to improve care for people with complex needs in a format that's engaging, attractive, and practical, and usable, with the goal of encouraging testing, adoption. In other words, we want to adopt this, then implementation, and then spread. And each of those words has a specific meaning, which I hope we'll get to perhaps in the panel discussion. So in a nutshell, the playbook's aim is to be a go-to resource for leaders who want to really get started on helping patients who have complex needs but may not know how to. Now, it's not that there's not a lot of information out there. There's too much. There's information from government, from payers, from the peer-reviewed literature and the trade literature, from healthcare companies and consultants, from ACO collaboratives and communities. So what we're trying to do is to cut through what can sometimes seem like noise or even cacophony and speak directly to the leaders who want and need to get started in catalyzing change. So far the playbook has something over 100 carefully vetted resources, and they're organized around 4 key questions, which again are not surprising. Why invest in redesigning care for people with complex needs? Who are these people anyway? What care models are most promising? And what are the key elements for redesigning care? You can also explore these resources through another lens, perhaps as a payer or a system leader or a policymaker, or through the lens of a specific segment. Frail elders, for example, you can look at them from that cut, if you will. All of the resources have been assigned a level of evidence. I know this because I personally helped to do that. But it's important to note that very few of them had what we regard as strong or very strong evidence by the usual criteria. If you look at the playbook, you're not going to find a lot of cluster randomized trials. There's a lot of expert opinion, but more importantly, there are a lot of case studies, both in the NAM book and in the playbook. And increasingly, these studies are rich sources of promising ideas that are certainly ready for testing, if not implementation and spread. For example, the Commonwealth Fund's recent report on CareMore's Medicare Advantage and Provider Network, absolutely stellar example of the kind of knowledge and experience that is embedded in these case studies. This is probably the most important thing I'm going to say. Both the playbook and the NAM report describe the key core attributes of the models. In the case of the NAM report, does a wonderful job of defining those attributes that cut across the models. The playbook looks at each model and says, to the extent possible, what are the core attributes of this model that must be replicated if you're going to hope to duplicate the results? To the extent possible, how can you do that? That's a very important thing that the playbook and the NAM report try and do. As the NAM report says, there's a delicate balance between precision, being very detailed, and generalization. So why is this so important? If you ask innovators about their model, they don't always tell you what the key or core attributes are. I call them the technical specifications that really do need to be replicated. And those details which should, and in fact must, be modified according to the context or different circumstances in which they're going to be tested and implemented. I had the privilege of spending some time over the last 2 years visiting a number of award-winning innovators in England. And I found the same thing. When I asked them, what are the key core specifications of your model that we ought to perhaps replicate? You're really inspiring. I want to stuff your model in my suitcase and bring it back to New England. But what are those core attributes? They often couldn't tell me. And they couldn't tell me which ones needed to be modified to work in other contexts. For example, in Sheffield, which has a fantastic thing they call flip discharge, which gets patients into their home so they can be assessed in their real environment. The key attribute was not that they reached team consensus in what's called the big room, or OMIA, from Toyota Production System. I can think of a lot of ways that I'll get better consensus at Boston Children's Hospital where I work. But what was key is they had criteria and a system for declaring a patient medically ready to go home, getting them in their home so that they could properly be assessed in their real living context. So that was the key component that they'd really discovered in their innovation. When looking at the resources that were curated for the playbook, or in fact making these visits in England or around the country, I find that most of them are not rigorous, and I grant you, we don't want to be doing endless health services research, but there is a balance here. If you're going to sell something to a health system leader in a multi-billion-dollar system like, let's say, UPMC, you probably ought to have some evidence that there are improved outcomes, that there's cost effectiveness, that there's a long-term return on investment, there's sustainability, and that you've looked for and mitigated any unintended consequences of that plan. And very often we don't find this. We really do need to be more rigorous when we develop and describe and do case studies on the models we're talking about. Now, as important as these formally curated resources are in the playbook, my colleagues will certainly tell us, and have told us, that what we really need are practical tips and tricks that help people implement these models. You know, it's one thing to say, as the NAM report does, you need to have a good care plan. That's great. If you're in a primary care practice or you're in a team, how do you actually go about doing that? You know, at IHI, we once did a call for great care plans. And astonishingly, it was really hard to find a care plan that was customized or could be tailored to the individual needs of the patient and the way they lived, that wouldn't just pile service upon service so that the patient living in their home, the frail elder, has to get to the door 15 times a week to open the door for a different service. So getting this kind of content, extracting the tips and tricks from the NAM report and putting them into a palatable, usable format such as a video or blog is going to be a really high priority going forward. Now, of course, the playbook aims not just to be a push system. If we're going to meet this desire to scale, it has to be a learning community. And there's a limit to what you can do on an online platform, but certainly rather than just pushing content at people, we should give them the opportunity to share their barriers and success in trying to use the resources on the playbook, ask them where there are gaps, and I'm sure there are gaps they'll define, but most importantly, as we were talking about just a minute ago, there are a ton of people implementing all over this country, and they may not have made it to the NAM report, and they may not have made it into print or in some way that we can access in the playbook. We need people to push that content at us so we can at least curate it and share it with other people. The last thing I'd like to say is there are some challenges in getting resources for the playbook and some gaps that I've noticed. First of all, there's a lot of great stuff, as was just pointed out by Bruce, in private hands. I mean, people have all kinds of great stuff that they're selling, and it's really hard to get proprietary material into the public sphere, and that's something we've really got to take on. We aren't talking that much about innovations in technology. We've talked a lot about innovations in data, and that's great, but technology really has the potential to be transformative in caring for patients with complex needs. We haven't really talked much about equity or disparities and the way the data and the tailoring of interventions needs to address the disparities and the multicultural nature of our society. And finally, what we do need to do and haven't started to do yet is to begin to look in other developed economies in particular, but also in less resource settings internationally, for models that could be applied here. The Commonwealth Fund has funded some very interesting work by the Duke Margolis Center on ACOs from other settings, also funded IHI to look for innovative models in developed economies. And we've got to really look at those. Just because we have the world's most unique and heterogeneous healthcare delivery system doesn't mean there aren't good lessons we can learn from abroad. So thanks very much for inviting me, and hand it over to Susan.